Everyone, thank you for joining us today. We will go ahead and get started momentarily. We'll just give folks another minute or two to join the session. Great, so I think in the interest of time, we will go ahead and get started. Good morning, good afternoon, good evening. My name is Sarah Kester, and I'm the Senior Manager of Global Community Engagement at the Sabin Vaccine Institute. Welcome everyone. Thank you for joining us today. We hope this will be a really engaging session, and thank you in advance to all of our panelists for joining us. Before we get started, I want to review a few housekeeping items. For our Francophone colleagues that are joining us, we are pleased to offer French interpretation. Please be sure to select French on the interpretation button, which is found on the bottom toolbar. And if you have questions, feel free to reach out to MJ in the chat. Otherwise, please raise your hand if you'd like to participate in the discussion, which will be taking place later in today's session. And we really encourage you to utilize the chat function to interact with the panel and fellow attendees. And I think MJ had just posted this in the chat, but we invite you to share your name, where you're joining us from, and what organization you work with to test it out and make sure it's working for you. So I am so excited to welcome you all to Boost's second session in our COVID-19 Listening and Learning series. This series aims to provide a platform for immunization professionals and others involved in COVID-19 vaccine delivery to share their perspectives on COVID-19 vaccine introduction. Over the next 9 months, we will be delivering dynamic sessions that are shaped by and respond to what you're experiencing in your day-to-day work. Since the beginning of the COVID-19 pandemic, advocacy and engagement from civil society organizations have played a critical role in overcoming the crisis, from ensuring essential services are available, to filling gaps in healthcare systems, to engaging with communities and sharing accurate, real-time information about how to stay safe. As COVID-19 vaccine introduction progresses around the world, CSOs and others continue to work to achieve equitable vaccine distribution and access. Today's session will explore lessons learned from CSO advocacy at national, regional, and global levels for equitable access to COVID-19 vaccines, with a focus on what has and hasn't worked and what work remains to be done. So during today's session, you'll have the opportunity to explore the role of CSOs in advocating for equitable access to COVID-19 vaccines, learn about the tools and approaches used by CSOs to successfully engage with national governments throughout the pandemic, and hopefully have a discussion about how CSOs can be better leveraged by decision-making authorities to ensure equitable access to COVID-19 vaccines. So before we kick things over to our panel, we wanted to take a quick pulse check to better understand the roles that you all play in COVID-19 vaccine introduction and how you engage with CSOs in your work. So I think MJ is going to launch a poll here. So we'll pull up the first poll and see where folks are joining us from. We'll give everyone a minute or two to respond. We'll give it, great, thanks MJ. So it looks like we have quite a wide distribution in terms of where folks work. We have folks from the local district level, regional level, national level, and global level. And it seems like COVID-19 vaccine rollout is quite varied, as we all know, across contexts in which our attendees work. For many, it seems like COVID-19 vaccines are available only for specified groups, and for others, it's widely available to the population. So I think this is great context for today's discussion. So with that, I think we have one more set of questions for everyone. We would love to better understand how you engage with CSOs in your work. So we have two more questions to have everyone answer, and we'll give folks another minute or two. So it looks like for many people, CSOs play a really active role in vaccine advocacy. And just over half of you currently engage with CSOs as part of your immunization work, which is really great to see. And we really hope today's conversation has some interesting learnings for those of you that already engage with CSOs, and perhaps inspires those that do not yet have the opportunity to engage with these critical organizations. Great. So today we're going to be hearing from CSO representatives and advocates from around the world to learn more about their experiences and the importance of CSO engagement in ensuring equitable COVID-19 vaccine introduction. So I am very excited to introduce our panel. So joining us today, we have Huma Kawar, a freelance journalist and CSO advocate from Pakistan. We have John Coonrod, co-founder and global coordinator for the Movement for Community-Led Development. Itai Rusike, the executive director for the Community Working Group on Health in Zimbabwe. And Buto Mpofu, the advocacy and communications manager for the Treatment Action Campaign in South Africa. Finally, last but not least, we have our facilitator, Nok Nlovu, the regional director of Africa with Adaptive Change Advisors and a very close collaborator of the Boost community. So thank you all for your participation in today's session. And with that, I will turn it over to the panel.
Thank you, Sarah. And welcome to everyone on the call. I see we have, well, the numbers are ticking. Thank you all for your attendance, and happy Africa Day. It's Africa Day today, and we're celebrating. I'm calling you from South Africa. My name is Mwabizita Ndlovu, and I'll be your moderator this afternoon, morning, or evening, depending on where you are. I'm already seeing a lot of familiar names from the Boost community in the audience. We enjoy interacting with you guys, and you'll have an opportunity to pose some questions to the panelists in the second half of this discussion, conversation rather, and would love to hear from you what your experiences are. And since this is a learning and listening series, we would like to hear from you as well. So let's get right to it. I'd like to introduce our panel. In fact, I'll just ask them to introduce themselves. Let me start with Yuma. Yuma, for people that don't know who you are, please introduce yourself.
Good morning, good evening, good afternoon, everyone. My name is Huma Kawar, and I'm based in Islamabad, Pakistan. Frankly speaking, I introduce myself as a diehard advocate for civil society engagement. I'm basically a journalist. I write on issues related to health and environment. And over the past years, I've been doing some freelance work. When in 2007, I was contacted by Gavi because they wanted to have a new set of window introduced in Pakistan to see if civil society who are working in different areas can come together and work for immunization. And since then, I've been advocating for civil society, and we've been working with civil society organizations. And now we have a consortium which consists of 41 civil societies who are working on immunization all over the country. So that's all from mine.
Wonderful. Thank you, Yuma, and welcome. Wuto, do you want to go next? Please introduce yourself. Okay, I think Wuto's figuring out his tech there. Itai, would you like to go next? Oh, there you are. Okay.
Thank you. Good morning, good afternoon, good evening. My name is Buto Mpofu, commonly known as Buto. I am the Advocacy and Communications Manager at the Treatment Action Campaign. Just a little bit about the Treatment Action Campaign. We're a patient-centered organization that is primarily people living with HIV. We have been working on issues around advocacy for about 20 years. A lot of it has to do with access to medicines, which is some of the stuff that I do. So this is a very powerful and platform for us, and I really look forward to engaging on substantive issues around that. Just to say that we have 8,000 members, and our 8,000 members are mainly lower LSM, so it's poor Black women, and as such, we always make sure that our approach is from the bottom up. I'm also interested in issues around my research is on migration, in migration and displacement, particularly on statelessness. So I look mainly on the subaltern, and I think this is also important for this discussion. Thank you for having me.
Thank you, Buto. Itai and then John. Itai, are you there?
Yes.
There you are.
Hi, everyone. My name is Itai Rusike. I am a public health activist and working with the Community Working Group on Health. The Community Working Group on Health is the health civil society network based here in Zimbabwe. And our aim is to enhance community participation in health in Zimbabwe through advocacy, networking, and community action. So we are an organization that is deeply rooted at community level, and we fight for health rights, health governance, and also working with the community structures to support health literacy. And we are an organization that was born in 1998. As you are aware, that is the period when the health situation in Zimbabwe, started to go on a decline, and it was important for us to enhance community participation. I'm happy to be part of this panel, and hopefully I'll be able to share our experience with the COVID-19 response and also with the vaccine literacy. Thank you very much.
Thank you, Itai. John?
Thank you. And thank you all for having me and joining us today. I'm John Coonrod. I coordinate something called the Movement for Community-Led Development, which is a civil society initiative launched alongside the Sustainable Development Goals in 2015 out of a frustration that the previous goals, the MDGs, were very top-down, no mention of community whatsoever. And yet nearly all of them require integrated strategies at the community level. So we started with a number of INGOs, but with the pandemic, we became a platform for more than 1,500 community-based organizations looking for opportunities for collective voice, for how to engage with their governments, for accurate information. Because as outsiders were pulled out of their communities, the community leaders stepped forward. And they really, really needed ways to work together to have a collective impact. So that's what we do.
Wonderful. Thank you, John. And maybe we can start there. Collaboration, you said, between CSOs and government. What is being done to advocate for broader CSO engagement at a global level, that is, with regard to the vaccine rollout? What can healthcare professionals do? What is the role of CSOs? Maybe if you can start us off there, we can have this conversation about the role of CSOs in doing this work.
Okay, I don't know whether that's to John or can I chime in? I see he's
John is
speaking.
is on mute. Okay, Buto, go for it. John, you guys have who's going first?
Buto, go first. You started.
Brilliant. Okay, sorry, I just saw you on mute, so I just took the opportunity. Okay, so I think there are a couple of things. There are two questions that you asked, and I think that we need to answer each separately. So the first one around what CSOs have done in partnership with government is that I think last year, if people recall, the South African and the Indian government put together, apologies. So if you remember last year, the the South African and Indian government put together a TRIPS waiver proposal. So the TRIPS is the trade-related aspects of intellectual property rights. That is a WTO thing around patent law. So this temporary waiver spoke to how do we ensure that for some time there won't be any that products that are needed to test, treat, and vaccinate against COVID are what you call this do not get patented and priced out of reach for particularly poorer countries. So it's very important for us in the global south. And we as civil society, we're very strong in saying we support this because I think it's very important. And I think the greatest example, I think, is around Adi Barkan, who we've done a few engagements with, who spoke to the now American President, Joe Biden, and asked him specifically around this issue. And Joe Biden said, yes, of course, I'm going to ensure that this is the case. But when he became president, he didn't fulfill that promise for a very long time. And by the time he did so, it became very important because it's now moving the dial in relation to how a lot of countries are reacting to the issue around accessibility and equity for poorer countries. So I think that's the power of civil society working and engaging the state in order to ensure that there's vaccine equity. So that I think that's the first thing. And the second thing around what can healthcare professionals do, I think there have been so many different actions that we've undertaken as civil society organizations. I think back to like MSF and how we've worked on world tours and how we've engaged in issues around putting out what you call this stuff for people to sign on to. And it's been really important because people who are in the know can actually voice out, can put their details down, and can actually then also share this and say, actually, guys, this is a very important thing for access. So health professionals can be part of that. I think health professionals can also be part of fighting against vaccine hesitancy, which I think we should speak about much more later. But I think that's part of the issues around what we can do and what civil society is doing in general. I'll just stop there.
Thanks, Buto. John, anything to add there? I know you've spoken to this issue of at a global level. How can we start to do this work of advocacy? But more importantly, at a hyperlocal level, there's work that's going on there. So maybe you can touch on that.
Yes, I think one of the things that is going, if anything is going to save us, is that people have been involved in this for a long time. Before there was a pandemic and before there were vaccines, there were the experience from Ebola that really emphasized the vital importance of community ownership, community leadership for a medical response, the issues of trust. That takes time. So having citizens involved for the long haul towards universal health coverage, towards citizen engagement in everything, both in the year preceding the pandemic, both UNICEF established new minimum standards for citizen engagement for all their programs. WHO's and the whole UN health system adopted a global action plan for SDG 3 that made community engagement one of the key accelerators. So there was actual people committed to this and people to whom you could turn. One of the things is that with Zoom and everybody on Zoom, having people from remote rural areas at the table in the same conversation with people in Geneva has been able to happen. And so there's a much more direct connection. One of the things that we've seen also is, as Buto just mentioned, the gap. There's a gap between the world, the rich countries, and the low-income countries. There's also a huge gap between communities and districts. You know, if you think of a woman farmer with her baby on her back, there's no way that she could even get to her district center. So having systems, having health committees, having education committees, having comprehensive public services within walking distance for people in rural areas, with a community health clinic as the anchor institution for community services, has proven really important. And then really having a partnership between, and particularly women, because they're continue to bear most of the caregiving responsibilities, working like really closely with nurse midwives and community health workers in general. Those citizens were really able to take dynamic action when the pandemic hit. They set up WhatsApp groups. There were phone trees in one organization alone that reached 500,000 community women, putting WHO messaging and accurate information into local indigenous languages around the world. So this kind of citizen action has been going on, will go on, and at every level, from the gap between the village and the district up to the gap between the richest and the low income at the global level.
Yuma, Bhutto and John have thrown us straight into this conversation about equity, right? And what work have you been doing as CSOs in Pakistan? Bearing in mind, most of these vaccine introduction projects are staggered. It's the healthcare professionals first and so on. How do we get to folks that are far-flung, that are hard to reach, who need these vaccines also? So please speak to your experience in Pakistan around equity.
Well, there's no doubt that my colleagues are speaking about the global level advocacy that civil societies do. But I personally believe that the civil society role at community level is equally, if not more important, because they are the eyes and ears of the community. I will take a few minutes to explain you my experience of the COVID-19 pandemic. When it started off, all of a sudden, at the end of March, everybody was facing a lockdown. And for 2.5 months, everything came to a standstill. It came as a shock to the entire country because we had never experienced something like this before. At that time, civil society, of course, were mobilized and they started working. But the initial, the target was to make the ends meet, because all the markets were closed, all the employment was shut down. There were no jobs. Everybody was at home, and there was just no livelihood means at all. So the civil society, which are also some of the civil societies doing some charity work in Pakistan, and philanthropy work in Pakistan, started, food distribution and caring and all those things. But then the civil society I'm working for, Civil Society Human Institution Development Program, which is known as CHIP, we realized that in this 2 months and 2.5 months of complete lockdown, when OPDs were also closed, there would be so many children who would become defaulters, of course, who are due for their pentavalent, their second dose, their third dose, and who are not being immunized. There were children being born in that period also. So we went to the government and we spoke to them, the district government and the federal government, and we told them that give us areas where you think a lot of mobilization is needed, and we will try to, resume immunization. And as the lockdown eased and the civil and the health centers started opening up, people were still hesitant. There was one cohort of people who were not accessing the health systems because of their consciousness of precautions and COVID-19 pandemic. There was another lot who don't even know that the health facilities have opened up. So we did rigorous mobilization, but we did not target the main city area. We took some slum areas. And we did rigorous mobilization, mobile miking, branding the van, telling everybody that the vaccination centers are open, trying to coordinate with the district government and bringing the vaccinators and making him sit in the outreach sessions, and then mobilizing and micro planning and bringing the children to the vaccination site and getting them immunized from what they had been defaulted for. There were so many new children born. Having done that, we realized that, and on the other hand, there was this big cohort of vaccinators who were also very apprehensive, because this supply and demand side was going together. The demand had just stopped and the supply was not opening up because vaccinators themselves are very apprehensive. So we provided them PPE and making sure, that both ends meet. But I would try to be very, very positive, because the positive thing about this rigorous social mobilization was that we came across communities who were zero dose, who had not been reached otherwise if we had not done this rigorous demand generation. So my take was, that civil society is basically eyes and ears of the community, and community mobilization is vital to vaccination and child.
And what role do you foresee CSOs playing post introduction to ensure that everyone who's eligible gets the vaccine?
I think as for the current, at the present, I would say that we have Pakistan, and like other countries, has started vaccination. It's been going on for the last 2-3 months, but we are still centered at the urban sites. We are still centered and we are still dependent on the mass communication, electronic media, print media for information sharing. The people or the women living in the rural communities, in the conflict-ridden areas, in the hard-to-reach areas, in the urban slums, do not have access to these tools. It is only the civil society who can reach these women on one-on-one basis, because they are not ready for passive information from the media. They need some kind of an interactive, convincing, some kind of addressing their myths, addressing their rebuilding their trust, addressing their misconception about this God knows unseen pandemic, which they think is there, but they don't know because there is no face to COVID-19. And I think here, it is vital that civil society work with the government and they reach these women who are the hardest to reach, because equity plays a very important role at every level. And whether it is the wealth quintile and the divide between the haves and the have-nots, or if you're talking about the women who are sitting in the remotest area of Khyber Pakhtunkhwa and does not have access, neither the information, because they do not go to health centers themselves. So it is the civil society workers who will give them the information, who will make them understand, mobilize the community leadership, make community groups who will make sure that once we have a smooth supply of COVID-19, you make sure that it reaches every person in the community, including.
Okay. And I know Itai, I saw Itai vigorously nodding his head there when you were talking about this urban and rural divide. Itai, you are in Zimbabwe, which has one of the more successful new vaccine introduction programs on the continent. What can people learn from how you've engaged through civil society? What strategies have you used? What's working? What's not working?
Yes, thank you very much. If you look at Zimbabwe, our COVID-19 vaccination rollout program started in February. And initially, because of the information gap, there was a lot of misinformation, disinformation, which then resulted in a lot of, vaccine hesitance and also low uptake, for the phase 1 of the vaccination. So what the government did was initially they started by targeting the frontline health workers and essential, those that are in essential services. But as civil society, we really got worried by the low uptake, even within the frontline health workers. And we really got worried so much that because we were expecting the frontline health workers to be in the forefront, of educating, the communities, the general public, for them, to be able to embrace the vaccine. But these are the very same people who were, hesitating, to take up the vaccines. So what we then did was to partner with community health workers. And for us, we realized that, community health workers are trusted sources of information, for community literacy. These are the people who live in the communities, they speak the local language, they identify, with their communities. So we then partnered and started training, community health workers and community influencers. And within the community, we also identified, some gatekeepers. And these were like the traditional leaders, the religious leaders, and also the political leaders, including, women leaders, youth leaders, and also leaders from civil society. And these became our, vaccine champions. These became our vaccine ambassadors. And because after the initial rollout, the government then moved to target those people with existing conditions and those aged 65 years and above, and eventually everyone. But it was very encouraging when the president himself, was what we then did was then to target at the highest level, to say, let's see the leadership, from the political, leaders, especially the president, his vice president, government ministers, taking the lead in terms of, being vaccinated in public. So when the president was vaccinated in public, I think that was our biggest, breakthrough, because we started to see a lot more people coming forward, to get vaccinated. So since February, so far we have vaccinated more than 600,000 people. And these are 2 doses, because we have been using the Sinovac, Sputnik, and also the Covaxin. And these are, initially, there were donations from China, donations from the government of Russia, and donations from India. And then the government of Zimbabwe also procured a lot more, vaccines. But generally, what we have seen now is there's so much demand that has been created because of the awareness, activities. But most importantly, in our awareness activities, we have been, putting people at the center, making sure that we have got an informed population about the importance of, being vaccinated. Why should one be vaccinated? And then we have been telling the communities that this is not the first time that people are getting vaccinated. Zimbabweans have been vaccinated for a very, very long time. So we have been demystifying all that, fake news on various, social media platforms, because initially there was that information gap. Because of the information gap, people were now getting, their information from other sources, and these are not the credible and official sources. And these were made mostly from their WhatsApp groups and so forth. But generally, I can say now, the demand is so high that some areas are running out, of the vaccines. Of course, we would want a situation where when we create demand, that demand has to be matched by, the supply of the vaccines. But generally, Zimbabwe has done very well in terms of, carrying out awareness. But most importantly, I think it has been the partnership between, government, civil society, church organizations, and most importantly, the community health workers.
Thank you, Itai. And I think it's very important to highlight that interplay between demand and supply, right? Yeah. What happens when you generate demand and supply doesn't match up? There's something that we can learn from that. Mbuto, I want to bring you back in here. TAC is advocacy work in South Africa, bearing in mind the kind of slow start that South Africa has had. What are you doing with regards to ensuring that there's accountability? And I know you do a lot of monitoring work through communities. Can you talk us through some of the strategies or tools that you've used to engage government through some of the processes that community generated work is focusing on?
Okay, thank you, Common. Well, that's a very good question. So as the TAC, what we've done is that we have an insider-outsider approach. So historically, Comrade John was speaking earlier on about how we learned from previous pandemics, and when HIV was hitting South Africa at its hardest, one of the things that we did is obviously we as an organization went out there and we took ARVs to show that, you're not going to turn into a zombie, for instance, and demystify a lot of the stuff that was happening. What we did back then was more contestation with the state, and people still remember us for that. But we've since then taken a much more nuanced perspective. So what we'd say we have is an insider-outsider approach. We do still go against the state in terms of litigation or any other thing when we feel that the state is wrong. And for instance, as we were speaking about earlier on, there's an issue of 190 million rand coming out of the public purse right now, which the story just broke yesterday around the misappropriation of funds on COVID communication with the Minister of Health. And we will take that up in terms of a more rigorous engagement with the state around that. But what we have done is that we've also created our flagship program, which is called Rechitse. So in Rechitse, we did a collaborative approach with other organizations of people who are living with HIV. And what we said is that we are going to do community-led monitoring. So we don't do community-led monitoring in the classical sense, where it's also saying we need to have, though we have gone through a rigorous CDC process around ensuring that we get ethical approval. We have a dashboard which is very, very, very beautiful and powerful and has all the information that anyone wants out there. We have one of the most, we have a rigorous process in which we have our questions are all individually, tested, and through that we have ensured that we have the best possible situation where the community owns the issues, where the community not only asks for and gets the data, but where we generate solutions ourselves. So we've done that in relation to HIV, but we have moved that to also incorporate COVID. We've moved that to incorporate issues around the TB response. We've moved that to actually look at health system strengthening. So those are the things that we now focus on as an organization. And this is manifested in so many different ways. So we collect the data, we analyze the data, we go back and we generate solutions with the communities being the ones who are leading the process, but where we get every other stakeholder involved. And then afterwards, we go back to duty bearers and we say, these are the issues that we found. These are the possible solutions that we work with everyone in order to come up with. And then it's a recommendation, you can then take it or not. It's at different levels. And then when that doesn't happen, then we do advocacy work in various formats. And this has been very good because we've been able to get into places that we'd normally not have been able to get into. So for instance, we've been able to get into what we call Operation Putuma meetings, where it's all the upper echelons of the Department of Health, where we are engaging with people who are who are like from PEPFAR and the Global Fund and other funders who are engaging with implementing partners. So when it comes to issues such as COVID, it's also important because now we're going to be in the room with the people who are actually making decisions, and we will be part of the decision-making process as opposed to screaming from outside only. So that's been a very, very powerful issue for us. I think I've spoken to people before, and we also release reports. Part of the things that we do is we then put all this data in the most manageable manner. So today we released this report around the state of healthcare in Mpumalanga, which is one of the provinces in South Africa. And it actually highlights all the issues around HIV, TB, around COVID. And it's very important because then people are able to then say, hey, this is the issue in my clinic. This is the issue in my what you call this, in my district. This is the issue in the province. And it's important for us as an organization that we take this very seriously. And then just to quickly, while I'm on,
one minute, comrade.
Yes, the issue around vaccine misinformation. One of the things that happened is that we also had a slow uptake as a country. The Sisonke trial, which was meant to be for healthcare workers, was meant to have about 500,000 people vaccinated. On the last week, there were only 300,000. So they opened it up to patient-facing organizations, which include us as monitors of and making people accountable in the system. So what we said is that after thinking about it, we're not queue jumping. We thought about those issues, and we said, we are going to be doing this to hold people accountable. But beyond that is also to say, hey, vaccines are important. So going back to the issue of when ARVs came out, it's the same thing now. We actually all took the vaccine, myself included, J&J, in order to actually say the vaccine is safe, and then speak about those experiences in the community, speak about those experiences on social media, etc. So that was very important.
Great. Thank you, Buto. The importance of having a voice in the room when decisions are being made. I think you've made that point. And for anyone who's interested, I think those resources can be made available in the Boost community that Buto has spoken to, the tools, and any other tools that our panelists make reference to. Yuma, I saw you raised your hand. Please go ahead. Your thoughts.
Just a small point. You talked about the supply and demand ratio and the balance between the two. Of course, you can't create demand when there's no supply, but you have to create demand to pressurize the government to ensure supply. Because what we are foreseeing is that for COVID-19 vaccine, to enable all the women or to reach the women, it will be very important for the government to change their rules. At the urban centers at the moment, we are going through strict internet immunization systems where you enter your identity cards, national identity card number, and you are through a mobile telephone, you're given the date and the time and the vaccination center where to reach and what time to reach, and you'll be vaccinated. But for a woman sitting in the remotest community, having no access to internet, having no access, not even having maybe a national identity card, because there's no concept of women having national identity cards in those areas, no education, no access to the outside world. You have to be flexible. Government has to change their rules. The government will make sure that, to reach those women, and even with the HR, you cannot have male vaccinators vaccinating those women. So all these things are, they have to be brainstormed. And once the pressure is created for demand, for ensuring that these women in the rural areas or even the entire rural communities are vaccinated, this process has to start soon.
Thank you, Yuma. Such an important point. I saw John's hand, then Itai, then Buto. I'll give you gentlemen a minute each, so we wrap up this conversation and invite the audience to interact with us. John, you go first.
Okay, great. Thanks so much. I have in one organization, something like 200,000 masks were produced in the first month of the pandemic. 500,000 leaflets were distributed door to door. As was mentioned, it's trusted people in the community. in local languages. Food packets needed to be prepared and taken to the destitute, particularly as a lot of migrant laborers returned and were to their villages and were sick. So either they were going to be, in some cases, attacked and stigmatized, or they could be taken care of. So this constant action by communities throughout the pandemic, setting up water hand washing stations, kind of resulted in vaccinations happening in these rural communities. And it was a continuity of citizen action from the very first days, knowing that there would, learning while doing about what you do during the pandemic, preparing people for vaccinations, creating the demand over 14 months.
Learning while doing. And John, you touched on this migrancy issue. I want to I hope Buto will touch on it in his minute. This idea of the movement of people and the other. Buto, how do we deal with that? You've spent some time on this.
Okay, so that's exactly what I wanted to speak about. So, when Huma spoke, she spoke about the issue of coverage, population coverage. And that's something that we as an organization have been very focused on because of a number of issues. I think civil society organizations in South Africa were very, very clear from the beginning that we need to ensure that we cover not in the 40 million people that need to be vaccinated. We need to also vaccinate people who are migrants. We need to vaccinate people who are stateless. We need to vaccinate people who are homeless and undocumented. We need to vaccinate sex workers. We need to vaccinate other key populations. And I think that it must be said that the state has reacted to that and said that they will do that. And that's something that we will hold them accountable to, because it's important that we do not, that the state does not only look at only a few people, particularly, and there's a particular worry in South Africa, given that it's an election year and South Africa's had a history of xenophobia. So this is something that we are really, really looking at. And I know that a few organizations are already thinking around litigation if that happens, but we always think that litigation is the last step. We need to do a lot before, which is like engage the state and preempt these things. One of the people in our organization, the chairperson, is on the ministerial advisory committee. And one of the things she's mandated to do is also speak about these issues and ensure that we center the other in every single response that we try and do in relation to the pandemic. So it's very important.
Thank you, Buto. Itai?
Yes, thank you very much. One of the interesting things that we have seen with COVID-19 is that it has, in a way, forced us to be very innovative as civil society. Like in our case, we have seen ourselves, working with the constituencies that we have never worked with before. And most importantly, if you look at the Zimbabwean economy that is highly informalized, the vendors, they are a critical constituency. So traditionally, when we talk of community health workers, we are talking of those health workers that are a kind of formalized and working, with the Ministry of Health and within their communities. But we have seen with COVID-19, we have seen, us, working with the vendors, and if you look at the Zimbabwean economy, where majority of the people, are not formally employed. So vendors become a very, very critical constituency. So if you look at the trainings that we have been offering, we have been now including, the vendors as some of the participants, for the trainings, so that they can go back to their constituency and be the, the foot soldiers in terms of further spreading, the messages. Similarly, rank marshals, they are becoming also a very critical, constituency. And these are the people who control, the transport queues, at public, transport ranks. And to us, they are very, very critical because as the passengers board, the public buses and so forth, and if you have rank marshals who are now, well informed about COVID-19, about, the vaccine literacy, they then become, the voice that is very critical. Also, we have seen ourselves working with the school health coordinators. We have never worked with school health coordinators before, because to us, we realized they were also a very critical, constituency, because of the reopening of the schools, and most of our schools are not necessarily boarding schools. So school kids, they commute every day, to school and back home. And it is important that they are also, well, informed about COVID-19. Similarly, we have been working with the, the agriculture extension workers. These are also very important, because especially in the rural communities, and they play a very critical role, and they are also respected. But we have also been working with the, the arts sector, the drama groups, and so forth, in developing, radio skits and television skits. And these radio skits are specifically meant, for the community, radio stations. And those radio skits are being done using the local language. So you would find we have got about 16 official, languages in Zimbabwe. So previously, you'd find most of the adverts, either they are in English, Shona, or Ndebele. But some of these adverts that we were doing, the radio skits, we were doing them using the minority languages, which would also, make those populations, understand the messages much better.
Inclusion, very important. For the remainder of our panel discussion, we have 15 minutes left, and I just want to invite some questions from the audience. I see there's quite a few questions. I'll start with the one from Adriana. Maybe Sarah, you can help me there and read out those questions.
Yeah, absolutely. So Adriana asks, a major issue is countries having adequate funding for operational costs of vaccination. Are there any good examples of CSO engagement and advocacy on this issue? What more can or should be done to ensure vaccines actually get out and into arms?
The whole People's Vaccine Campaign has been pushing that issue really hard. I know that CARE just published a report showing there's basically a 5-to-1 budget requirement. $5 is needed for the delivery of $1 per dollar of vaccine. So there's a lot of advocacy going on, particularly with the bilaterals and the World Bank, to ensure that countries get the delivery funding that they need. So that's a very hot topic.
Any other responses from the panel? Sarah, let's pick up the next one.
Great. So the next question is from Analia. A critical point is human resources to deliver the vaccines. I think this is something we also hear from our Boost members a lot, that there's a shortage of human resources that are really necessary to properly roll out vaccination. What could be the role of CSOs to improve this point, improve human resource capacity? Curious, Bhutto or Itai, if you've done any work around this in your roles.
Okay, so my experience is a little more complicated. So because South Africa already has a human resource shortage, a serious human resource shortage, I think there was an estimation that we need at least 35,000 more healthcare workers before. This was way before. What has happened is that there's been a situation where human resources and finances have been taken away from some other instances. So like we've had money taken out, like 5.6 billion over the next 3 years taken out from HIV and TB response. We've had human resources taken away from the HIV and TB response. And what it's left is that both have come underserved, and it's a very big problem for us. So we've been involved in a lot of the advocacy to ensure that we get more human resources. And so we've been doing it at particularly provincial level, where South Africa's healthcare system is different because you get money at national level, you get money from global funders, and then you get money from provincial funders. At provincial level, it's called a provincial equitable share, which is never published really, but like you get a chunk of money at the provincial level and you get to decide as a province how you cut it up. And so one of the things that we've been doing is to advocate for more money to go into human resources so that both the HIV and TB response and the COVID response are sorted out. So at the beginning of the year, we found out that healthcare workers were going to be removed from the Eastern Cape because they only had 1-year contracts for COVID. And through advocacy and screaming about this and stuff like that, they managed to keep their jobs, which was very important because now they're able to engage in terms of vaccination. It's still not enough. We recognize that. And it's something that we are continuously working towards ensuring that there'll be more human resources going forward for all pandemics. So it's not just issues around COVID, but we are very acutely aware that TB is still the #1 killer, for instance, that we haven't reached our HIV goals from 90-90-90 or 95-95-95. So yeah.
Itai, you had your hand up as well?
Yes. For us in Zimbabwe, before COVID-19, there was a freeze, on employment of health workers. So we had almost 4,000, qualified nurses that were sitting at home because they could not be absorbed. So when COVID-19 started, as civil society, we started to advocate for the unfreezing of those posts. And I'm glad to say almost 4,000 new posts were created. So we had a lot more nurses employed when COVID started. But of course, there was now the challenge of shortage of PPE for those nurses. And there were also challenges with the late payment of their COVID-19 allowances. And those became also our advocacy issues to then say there was need for adequate PPE to the frontline health workers. And the government of Zimbabwe all along has been talking about a budget surplus. So we then also started pushing to then say, let's use the budget surplus to employ, additional healthcare workers. Let's use the budget surplus to also make sure that there's provision of adequate PPE and also payment of the, COVID-19, allowances. So COVID-19, I think, in a way, helped in getting, those nurses that were just sitting at home because of the freeze, to be absorbed by the Ministry of Health.
Thank you, Itai. Sarah, I wonder if in the last few minutes we can hear the voices of our audience. I see Dr. Ismaili has their hand up. Maybe we can start with her. Maybe let's take 2 questions from the audience and before we close to the panelists.
Great. So Ismaila, please unmute. You should be allowed to speak.
Hello, can you hear me?
Yes.
Yeah, good afternoon from my side here. My name is Ismaila Ibrahim Edego. I'm an independent mediation consultant in Zaria, Nigeria. My concern is, if you look at some of the underserved, disadvantaged populations, you see that primary healthcare services in those areas are very poor. such that those people struggle even with common ailments to resolve their issues. Some of them need to travel to the cities, to the towns to do so. So when issue of immunization of this kind comes, you see the government and civil society organizations trying to take these vaccines to them, and they become skeptical. We had this experience with polio eradication, where they say we need common malaria medicine and services in our primary healthcare centers we cannot get. Now you are bringing polio vaccine to our homes. We're having same issues as related to COVID-19. I think we need a different approach, or what will civil society organizations do to resolve these kind of issues? Make advocacy to government so that in the near future, we can be able to surmount these kind of challenges. That's what I want to add from my side here, out.
Thank you, Dr. Ismaili. Folks who would like to take that question. Go ahead, Itai.
Yeah, I think this is a brilliant question from Ismaila, because if you look at COVID-19, it has further exacerbated, access to essential services, for, those that are in hard to reach, communities. And it's a common issue now that we hear, especially in most African countries, because previously most of them were underserved. They were not able to get access to basic, essential healthcare services. And it then becomes difficult even to get into that community and say, we are now bringing, a COVID-19 vaccine when they were failing to get, the other basic, services. So it is important, I think, for us as civil society to continuously bring back, the primary healthcare issue on the health agenda, and making sure that our governments, they go back, to the primary healthcare principles. If you look at a country like Zimbabwe, the first 10 years of independence, everyone still talks about the first 10 years of independence because we did so well. Our health outcome indicators were excellent because of the primary healthcare approach. So I think it is important that, especially African governments, we need to go back to the primary healthcare principles. We need to go back to the primary healthcare approach. But most importantly, we need to put domestic resources, to the health sector and move away from this over-reliance, on external donors, to support our health delivery system. And there is no way Africa is going to achieve universal health coverage by depending on external donors.
Thank you. It's an important message on Africa Day.
Could I add a
John,
point?
go for it. Go for it, John.
Zimbabwe's first 10 years was inspiring, and part of it was it leveraged everybody's resources. So there was only so much money for tin roofs, but if communities could build schools up to the lintel, the government was able to give them a tin roof. So mobilizing the work of communities to build or repair the infrastructure, there's seeing people as the solution rather than as beneficiaries or a problem is really key. And there's so many great examples across Africa of communities stepping forward to close the gap, to ensure that their community has a clinic or a subclinic, or that those scarce professional resources are used to the utmost efficiency. People can solve these problems and are doing it. And so, shifting power and shifting resources to the communities to solve their own problems has proven to be a really successful strategy in sub-Saharan Africa in particular.
Wonderful. Let me ask Yuma and Buto in that order. In the same spirit as John, what are your parting thoughts that you leave with the audience?
I think civil society has great potential, and for community empowerment, I think this is the best tool that we can apply. It's only that the governments, I would say, need to really realize and not be threatened, rather, and take them on board because we are there to support them. and we are not taking any credit for it. But if it's a joint venture and we are all for, the health for women and children and well-being of communities, we have to work together. And this is high time, that we should shed off our egos and work together. So that's my message.
So my message is that I echo some of what Huma says. I think that civil society organizations have a critical role to play, but I think that so do all stakeholders. So as vaccine experts, it's important that you are part of it. There was a question earlier around what can be done, and I think treatment literacy is very important. We've managed to speak to comrades in the past who tell us about the vaccine process, who tell us about issues around what we can do in our advocacy work. So that's what vaccine professionals can do around this issue. And we can all work together. The one thing that I feel sad about in relation to what we've been speaking about is that we've been speaking about public power the entire time and holding public power to account. But there's a critical space around holding private power to account, right? And we need to speak a lot more about that and how we all have roles to play within that space. And I think this space is opening up an exciting time for us, where we can all be part of something in terms of change. And I can't wait to see what happens within the next year or two.
Wonderful. That's a good place to leave it. Thanks to our panelists for a rich discussion around the role of CSOs in this time of COVID. I want to hand it back to Sarah to lead us to close.
Great, thank you. And I would echo those thanks to our panelists. I think this is a really interesting discussion. I think echoing Bhutto's point that it's an exciting time, and it'll be really exciting to see what happens over the next year, particularly with CSO engagement. So before we close out, I just wanted to highlight a few additional resources and other engagements that might be relevant to you as you continue to engage in this work. We first want to highlight the COVID-19 Vaccine Introduction Toolkit. This is a repository for resources and training documents designed to help countries in COVID-19 vaccine planning. We invite you to explore this toolkit, which is designed by our colleagues at WHO. It is frequently updated with new tools and resources and is available, as you can see, in a variety of different languages that are, again, being updated on a regular basis. We would also invite, for those of you who are new to Boost, we would invite you to join the Boost community. Our global community seeks to support immunization professionals in every aspect of their work. And there are a number of different ways for you to continue engaging around the topics discussed today. We recently launched a learning group on the Boost community platform, which is a great place for you to continue the conversation with your peers. And hopefully we'll see some of our panelists in that group in the coming weeks as well. And then we would also invite you to join two different Telegram channels. We have our Boost Telegram channel as well as the Telegram channel for TechNet. These are places where you can engage with other immunization professionals on technical topics related to COVID-19 vaccine introduction. And then finally, we are excited to announce the launch of Sparks. Sparks surface real-time moments of innovation or overcoming challenges. A spark can include, but is not limited to, a successful rollout of a new tool, engagement of the community, or the development of a strong partnership. So Sparks are really an opportunity for you to share your successes with the broader immunization community. And we would invite you to share your Spark today. For those of you that are members of the Boost community, you'll be learning more about this, I believe, tomorrow as we officially launch Sparks. But we would really invite you to share your successes, your learnings, and have an opportunity to highlight those to the broader Boost community as well as the broader immunization community. Finally, as we mentioned at the beginning of today's session, we know we're really scratching the surface here. As we plan for future engagements, we want to understand what you need and how we and other global partners can best support you as you navigate the COVID-19 vaccine introduction. So keep an eye out for follow-up materials and an announcement of our next session in the next 2 weeks. So once again, thank you to all of our panelists, our facilitator, and all of you who tuned into today's session. We're really looking forward to continuing these conversations with you over the coming months, both live as well as on the Boost platform. Have a great day, everyone.
Thanks, Sarah. Thanks, everyone.